Well, the topic I was given is trying to convince you about the combination of pulmonary vein isolation and left atrial appendage occlusion. It's a good way to treat at least some of our patients. And which is the rationale to combine both procedures in one? Well, first of all, because I think that everyone would agree that although catheter ablation is the most effective treatment to maintain sinus rhythm in patients with both with paroxysmal and persistent atrial fibrillation, it's just considered as a symptomatic treatment. And the overall consensus is that it should not be indicated as a method to stop anticoagulation. Why? Well, first of all, because recurrences, and I'm not talking about only symptomatic recurrences, but also silent recurrences of the arrhythmia, are quite common early and late following catheter ablation. So I will show you just two recent trials on catheter ablation. This is the RAF2, which was a prospective trial that randomized in a 1-to-1 ratio 127 patients with paroxysmal atrial fibrillation without previous treatment. So there were very nice patients in the early stages of the disease. And they were randomized to a control arm of antiarrhythmic drugs and ablation, one procedure of catheter ablation. The primary endpoint was the time to first recurrence of symptomatic or asymptomatic atrial flutter, tachycardia, or atrial fibrillation. And as we can see here, it was, of course, an intention to treat analysis, and with a high rate of crossovers from the antiarrhythmic drug arm to the radiofrequency catheter ablation, with roughly 40% of the patients with antiarrhythmic drugs required catheter ablation at the end. And as you can see here, of course, catheter ablation was superior to antiarrhythmic drugs in terms of recurrences of symptomatic or asymptomatic arrhythmia, but roughly 50% of the patients in the catheter ablation arm had any kind of atrial tachycardia recurrences. This is another study. In this case, is for persistent atrial fibrillation. Again, very similar design, prospective and randomized trial on 146 patients, comparing antiarrhythmic drugs and one procedure of catheter ablation. And the endpoint in this case was any atrial tachycardia 3 months after the blanking period. And again, as you can see, almost 30% of the patients in the ablation arm had any kind of arrhythmia recurrences during the 6 months follow-up. Another reason to not stopping anticoagulation after a catheter ablation procedure is that in fact, during the ablation, we destroyed a significant portion of the atria, and the impact of this phenomenon in the stroke risk, in embolic risk, is simply unknown. We have no randomized trials designed to assess the safety of stopping anticoagulation after catheter ablation. And this is why most current guidelines do not recommend to stop anticoagulation after what we could feel as a successful ablation procedure. You can see here the Canadian Cardiovascular Society guidelines, where you can read that AF ablation should not be indicated as an alternative to oral anticoagulation, and if the patient has a high thromboembolic risk profile, he should continue on anticoagulation. The same holds true for the American guidelines. In fact, the indication of catheter ablation with the sole intent of stopping anticoagulation, it's classified as a class 3 indication, in other words, harm, and the same for the European guidelines. Another reason to combine both procedures is that both interventions can share some procedural issues and technical requirements, and this is In fact, a combined approach, for example, could reduce the need and risk of a repeated left atrial intervention. Both procedures share the need of left atrial access, transeptal puncture, of course with some difference between them, but you can deal with that problem during the procedure. And in most institutions, we use general anesthesia for both interventions. A third reason is that you could obviate a new anticoagulation perioperative period in the case that left atrial appendage occlusion become desirable during follow-up. And last but not least, both interventions may benefit mutually from some pre- and intraprocedural assessment techniques. This is, for example, the case for CT scan. We routinely use CT scan for pulmonary vein isolation, and you can get some information about the left atrial appendage morphology with this CT scan. On the other side, you use routinely transesophageal echocardiography for the left atrial appendage occlusion procedure, and you can benefit from this in the pulmonary vein isolation part of the procedure. And finally, I think that this is the most important thing about my talk. I think that the combined procedure would cover the full clinical spectrum of atrial fibrillation in terms not only of antiarrhythmic and symptomatic effects, this is covered by the catheter ablation part, but also the antiembolic intervention in the case of the left atrial appendage closure. And this issue has been shown to be safe according to some observational series. We have here what we know to date so far with this approach. The first one was the study from Swans, the Dutch study, on 30 patients with paroxysmal and persistent atrial fibrillation with a single-shot technique of atrial fibrillation ablation and the Watchman implantation with high success rate, very high rate of oral anticoagulation at the 1-year follow-up, and also freedom from arrhythmia. The study from Romanov, in fact, was a randomized study to assess the rate of atrial arrhythmia recurrences between patients only with pulmonary vein isolation compared to pulmonary vein isolation and left atrial appendage closure. And this is our contribution on 35 patients with paroxysmal and mainly persistent atrial fibrillation, which underwent a concomitant PVI and left atrial appendage occlusion procedure with CHATS-2 of 2, a Hasbled of 3.1, with Watchman and ACP, with a high rate of success. 78% of the patients were free from atrial fibrillation during follow-up, and 97% were free from anticoagulants at the 6 months follow-up. The main reason to indicate both procedures was history of major bleeding in 48% of the patients and personal preference in a quarter of the patients. The main complication was pericardial effusion in 3 cases. And as you can see, this approach of combining both procedures has been also taken by the consensus statement, the European consensus statement. In very selected cases, this combination seems to be a valuable and practical approach in patients with significant risk of thromboembolic risk undergoing an ablation procedure to treat symptomatic atrial fibrillation. So, ladies and gentlemen, and I beg you to not misunderstand me. I'm not talking about who's going to do the procedure. Doesn't matter. This is another fight. I'm not talking about electrophysiologist or interventional cardiologist, but I think that if provided that the patient has a formal indication for both procedures, and especially if they have a high embolic or bleeding risk, if you can expect an anticipated reduced efficacy of catheter ablation alone, for example, in cases of very enlarged left atrium or persistent atrial fibrillation, or in case of personal preferences after a thorough discussion, the combination of both procedures, a combination of PVI and left atrial appendage closure in a single session, could cover the full clinical spectrum of atrial fibrillation in terms of antiarrhythmic breaks and symptomatic effects, as well as an antiembolic intervention. Thank you very much.